Welcome to today's World Thrombosis Day expert discussion on thrombophilia testing and the management of the thrombophilic patient. We are pleased to have you joined us in this interactive and engaging discussion on thrombophilia. Today, our expert panel will discuss evidence-based approaches to thrombophilia testing and how proper testing can improve patient outcomes. In the name of my employer, Sysmex Europe, I would like to express our gratitude to the ISDH for granting us this opportunity to support this webinar. I'm Dr. Andreas Rechner, your host and moderator. I work as a Senior Scientific Marketing Manager for Haemostasis at Sysmex Europe in Hamburg, Germany. And I look back at more than 20 years of experience in the fascinating world of hemostasis. Our first speaker is Dr. Lana Castellucci, Associate Professor in the Faculty of Medicine at the University of Ottawa and scientist at the Ottawa Hospital Research Centre in Canada. Dr. Castellucci has served as the chair of the World Thrombosis Day Steering Committee. We are also joined by Professor Cihan, a professor of hematology at the Medical University of Vienna in Austria. Professor I currently serves as a member of the World Thrombosis Day Steering Committee, and we are very pleased to have him with us today. Thank you both for being with us today. Before we begin our discussion, we would like to hear a word from each of our experts about their background and expertise as it relates to today's discussion. And we will start with Dr. Castellucci. The stage is yours to give your introduction. Thank you.
Hello, everyone. It's a great pleasure to be here today. Thank you, Andreas and Cihan, for being here with me. This is going to be a great discussion. As you mentioned, I'm a thrombosis physician based in Ottawa, Canada, and the thrombophilia workup and management is a very common scenario that we see in our clinical practice. It's also quite relevant to the research that I do, which is largely based around acute VTE and anticoagulation management. So this is a really great opportunity to tie in the thrombophilia questions with my clinical practice and research. As you mentioned, I am the past chair of the World Thrombosis Day Steering Committee, and that committee has done a lot to educate both healthcare practitioners and patients about relevant thrombophilias, which is very important, and I'm sure we will touch upon during our discussion today.
Yeah, thank you, Lana. I give the word to Cihan to give his introduction. Please.
Hello, thank you so much. So my name is Cihan. I'm trained in internal medicine and hematology, and I have a very special focus in thrombosis and hemostasis, and I'm working at an institution where we have a large thrombosis service, and questions around thrombophilia are asked every day. So we see a lot of patients who are referred to us with regard to thrombophilia testing, or who have had thrombophilia testing and nobody could explain them their tests. And maybe I would also like to mention, when I started with research, one of my first research projects was to identify novel thrombophilic risk factors here. And that was quite a learning for me, and it changed a little bit my view since then on this topic from a scientific point of perspective.
Okay, thank you for this introduction. I will also give a few words on my, let's say, like perspective and expertise. As I said, I worked for 20 years in the field of hemostasis. I started with platelets, and they are, let's say, like key mediators of more like of arterial thrombosis. So the subject thrombosis was always in the center of my interest. And during various roles, it's for us from a let's say like a diagnostic company point of view, it is interesting to how we can help the clinician in their quest to really treat and discover thrombophilic patients. So that's for us. That's why it's so interesting to hear the view and the opinions of real experts in the field on that subject. And with that, I'm very pleased for that discussion. But before we start, we would like to hear from you where you are from. So you can later in the top comment box leave where you are from, so that we have this information which will be valuable to us. So with that, I would like to start our discussion, and I would like to start with one example. We have we start with something like you have a patient, a young adult, coming to the clinic, and is diagnosed with a thrombosis, with a deep vein thrombosis in his legs. So he's treated for that. He is diagnosed and treated, and the DVT has been resolved. So what happens to this young patient where you wouldn't expect something like a thrombotic event? Maybe with Lana, you start with your perspective on that, let's say like very common case.
Thank you, Andreas. So this is a common scenario where we'll see young people with VTE, and I think young is important to define when we talk about thrombophilia. Many of us often use the threshold of 50 to 55 years, some people up to 60 years to define thrombophilia in a younger patient population. And I think it helps us to determine background and understand if there is prior personal history of VTE in this individual, their family history, of course, and additional questions around the circumstances of their VTE diagnosis. Were there any strong risk factors, such as an injury or trauma, major surgery? And all of those things help us to determine whether or not it's provoked, and strength of that provoking risk factor if it is there. And if none of those exist, then is it considered unprovoked? Those are things that I think about before deciding on whether or not I'm going to pursue thrombophilia investigations. And it's also important to understand if they have any bleeding risk factors as well, because all of these things may influence our decision-making for duration of anticoagulation and type of anticoagulant that we're going to use.
Mm-hmm. Yeah, thanks for that insight. I mean, with the young, actually, I didn't specify it. Really young, like 30.
Okay.
That's for me like an unusual age for thrombosis. So, Cihan, what's your view on that case?
So I absolutely agree with you, Lana. I mean, first of all, this is really a young person, so 30, yeah, so no doubt, yeah. But in addition, so first of all, the first action in such a patient would be to treat the patient. So according to the standards that we have, and then we start to think what else to consider here, of course. And in such a patient, and definitely thrombophilia testing is a question that will be discussed.
Yeah, that's always like let's say like the starting point if you look to guidelines and alike on that subject. And the question is then, okay, thrombophilia testing, what does it mean? What will be tested? I mean, for those who don't know it, it might be interesting to have like an insight which of the coagulation factors or inhibitors will be tested. Maybe we continue with Lana yet again.
Certainly. So I think when we consider thrombophilia, we look at hereditary or genetic thrombophilia and then acquired thrombophilia. And oftentimes we run into the question of whether or not we should be performing genetic or inherited thrombophilia testing. Acquired thrombophilia testing for me in this patient population is largely limited to antiphospholipid antibody testing. If this is a standard lower extremity DVT, I would not generally pursue other things unless there are findings on history or laboratory markers that would make me want to pursue other acquired thrombophilia investigations. The question of whether or not to pursue hereditary thrombophilia testing, again, depends on prior history of VTE in the individual and if there's any family history as well that can help guide that decision making. we often see that thrombophilia testing may not influence our treatment duration and risk of recurrent VTE. And so it isn't always indicated. And that's a discussion both with the patient and their family members as well for that shared decision making.
Yeah, the hereditary ones are classical. I mean, there are these endogenous anticoagulants we have, which are namely antithrombin, protein C, protein S as a system together, which work as our endogenous anticoagulants. And if they are missing, that's these hereditary deficiencies. So that's what you would what the guideline says. Okay, that's what you should look for. Are there any deficiencies for that? Would you include anything else at the moment, Cihan?
Yeah, I think this is an important topic, actually, what you're mentioning. So, what includes the thrombophilia panel? And this is probably from institution to institution very different. But the classical thrombophilias, of course, are the first thing everybody's thinking of is factor V Leiden mutation and inherited thrombophilia leading to APC resistancy. And of course, the deficiency, as you mentioned, of the natural anticoagulant should be part of this thrombophilia panel, like antithrombin, protein C, and protein S deficiency. Then we have, in addition to the factor V Leiden mutation, the prothrombin gene mutation, which should be in this core panel. And then we have among the acquired thrombophilias, antiphospholipid antibodies. And here I would mention the three important ones. First of all, lupus anticoagulant, anti-cadolipin, and anti-beta-2 glycoprotein antibodies. And I would limit in my clinical practice thrombophilia testing to those factors. But there are certain regions where the thrombophilia panels are capturing or covering many other factors that I would not consider as the classical thrombophilia, thrombophilias. I don't know, what is your opinion, Lana? Would you add something else into your panel?
That's a really great point, Cihan. We do a similar panel as what you described if we're going to pursue thrombophilia testing. We often are referred patients who have had thrombophilia testing for a number of reasons, where a whole panel is done, and we are referred them to discuss the findings, which unfortunately for the patient, where they think they have perhaps an explanation for a clinical condition, it ends up being not a relevant test. And one that I'll mention is the MTHFR gene mutation, where we know that it doesn't carry any enhanced thrombophilic parameters. And so that's a test that is often done for investigations of recurrent pregnancy loss, for example. And we know that it does not carry an increased thrombotic context to it. And so, again, I think that is really important to highlight those panel investigations that are done.
Maybe we should, I think this is so important because my clinical experience is based on, we are covering a big region in Europe where people have a migration biography or background. So where I see what in other regions is included in the thrombophilia panels, and such SNPs like single nucleotide polymorphisms like the MTHFR mutation or other SNPs in the past probably have been associated once in a study with risk of thrombosis, but who do not have really a clinical relevance because they are so frequent. They are seen in 15, 20, 30% of the population. And with regard to the MTHFR mutation, I think we made a call to action as a World Thrombosis Day steering committee some years ago and published a paper that it should not be included in thrombophilia panels. Maybe if this information is spread out today, we have reached a lot.
Absolutely.
Because it has consequence. It's positive. You will find a variant in a certain number of people, but it has not a clinical consequence. But we will probably talk a little bit later about the consequence of thrombophilia testing and its relevance.
Yeah, I mean, we have these local differences. I mean, also like certain genetic disorders are spread over the world. I mean, there are clusters. I mean, take like the factor V Leiden, which comes from Leiden in the Netherlands, where this was discovered. It's very much focused on Caucasian people, where this is very much more frequent. And this is also like in terms of testing. But coming now from the lab point of view, we have these. I think we are quite similar in the aspect. Okay, what we should test or which parameters should be looked at. Another question is, I mean, if people ask, okay, what are the tests which you recommend? Because I mean, what we also know about these deficiencies is that they are always clustered or classified into two different types: a quantitative deficiency, often a type 1, and a so-called qualitative deficiency, where people have the protein in their blood, but it's not working as it should be. So there are guidelines and recommendations. So what sort of parameters should be looked at if we do thrombophilia testing in the lab?
Maybe I would say we need a proper test, and I think especially you're referring to the natural inhibitors of anticoagulation, antithrombin, protein C and protein S. So here we need a really good test. So there you could measure the protein, but the amount of protein might not give you the full picture, but you need also the activity-based assays. And here we have, I think, good guidance and recommendation guidelines which tests to use. But from a clinical perspective, I would say we have to rely on the lab to use a proper test to give us a reliable result. Yeah.
Yeah, and if I can add to that, Cihan, I think the timing of testing is also very important for those natural anticoagulants, especially in the early setting. We don't want to measure when people have an acute thrombosis because we expect that their levels will be lower. And there may be some interference with the different anticoagulants that we have and the lab assays. So it is important to work with your laboratory to understand what the assays are dependent on in terms of anticoagulant interference and whether or not, for example, if a patient is on a direct oral anticoagulant, can that DOAC be neutralized if you are measuring while someone is on anticoagulation? And then, of course, the alternative is to try to measure at the completion of therapy so that you can have an accurate depiction of those levels.
I think you mentioned some of the very relevant pitfalls, Lana, especially. So we really do not want them to be tested in the acute phase, where probably it will mimic some deficiency as it is used in an acute phase. Yeah, or when patients, I mean, there are some pitfalls when patients are measured on anticoagulants. So we know protein C and protein S are vitamin K dependent anticoagulants, anticoagulant proteins. On vitamin K antagonists, you will have lower levels. Antithrombin activity will be higher when you are on a DOAC. Yeah, so it will give you a false result, probably. Yeah, a false negative result if someone would have antithrombin deficiency, and lupus anticoagulant will be positive on a DOAC here. So I think the timing issue is very important if you are going to test for whatever reason for thrombophilia.
Yeah, I mean, maybe for our audience to understand that, because for instance, for antithrombin testing, there are two functional antithrombin assays, which are either factor 10A based or factor 2A based. And of course, if someone is receiving, I mean, we stay with our case. I mean, if that patient is receiving a DOAC which works against factor 10A, of course, a factor 10A assay will be massively influenced by that assay. So if you don't know that, you will get a result which is completely meaningless. So, but there are nowadays means and measures how you can basically remove certain anticoagulants, not all of them. The DOACs can be removed, but if you have a vitamin K antagonist, there's no way to remove that because it works via a different mechanism. And that's why it's always important to have this, from my experience, to have this communication between like the clinician treating the patient and wanting to know, is there something hereditary in the world of factor deficiencies or antithrombin, protein C or protein S deficiencies in the context of the treatment. So is this how is this communication working in your hospital, for instance, in Canada?
So I think for us as clinicians, the best thing for us is the timing of when you're going to measure. And then if there is a result that is unexpected, I do speak with our pathologists in the lab to determine what type of assay they're using, because oftentimes the assays may change without us knowing. And so if there's an unexpected finding, then I will contact them to understand what is the assay and any interference from anticoagulants. Oftentimes when I am testing for thrombophilia, I will try to stop anticoagulation so that we can have as accurate a finding as possible. But in some patients who may be considered high risk for recurrence, it is always difficult to entirely interrupt anticoagulants. So sometimes trying to measure an assay at a trough level of an anticoagulant can be used. But again, that's not always reliable. So if there's any unexpected findings, I will speak to the lab pathologist to determine what the type of assay is and best way to navigate that.
Yeah, understood. So I guess this I mean, and Cihan, you mentioned that before already, that to really know what we test and when we test it is very important to get like an accurate result for the patient, and also like to see how the further treatment will develop. Yeah. So what I mean, if you have a patient, for instance, now in Vienna, and he's diagnosed with an antithrombin deficiency. So what happens to that patient? What is the management step? Because they have now this what we call thrombophilia, but what is the consequence for such a patient?
Yeah, I mean, I'm my first step, of course, is to confirm the antithrombin deficiency. Yeah, so we have also the option of like genetic testing to confirm the antithrombin deficiency, and then also to differentiate between type 1 and type 2 deficiency here. So, and then the consequence, of course, is it depends on the patient profile here, I would say. Yeah. So, I mean, I would go probably one step back. So first of all, you should, if you are going to test for thrombophilia, you have to define what is the reason you are going to test for the thrombophilia. Maybe this is so important. So to really clarify the reason, because my experience is it's the other way around. People are testing, colleagues are testing, and they are hoping to have normal results. But sometimes they get pathologic results and they don't know why, and they don't know how to interpret results, and they don't know what the consequences. So I would really advocate, first of all, before you test, know the reason or define and clarify the reason. So is it the reason because you want to make treatment decisions in the acute phase, or as Lana mentioned, you want to make decision on the duration of anticoagulation? Is this going to answer your question? Is this because you have like, and this is happening frequently, a decision in a young lady to not to take oral contraceptives? Is it a decision where or is this the reason, for instance, in this person that you mentioned, if it's an unprovoked VTE and it's in a young person, you don't have any other classical clinical triggers, maybe you want to search for an explanation, yeah, in such a case here. And sometimes it's also a patient request. They come, they read in the internet, and they say, oh, I want to have a thrombophilia testing. And you have to understand them. What could we expect from thrombophilia testing? What will it tell us, and what it will not tell us? Yeah. So I think this is in this process, this is important to clarify the reason and the indication for thrombophilia testing.
Yeah, I think brings me to the need of classification. I mean, you said you have to know why you're testing, but I mean, when we stay with this example from the beginning, you have now this unprovoked VTE event in that very young adult person. Yeah, so that there's a high likeliness that there's something, let's say, like wrong, not wrong is maybe the wrong, not the right word, is that there's some deficiency present in that patient. So you will maybe test that the panel of assays which are available to screen for factor V Leiden, to screen for antithrombin deficiency, where you would normally use a functional test. The same applies to protein C deficiency, where you also have a chromogenic functional assay. And only for protein S, you typically use the antigen assay to screen for a protein S deficiency. And there are also like these different types of functional deficiencies, namely with antithrombin, you have these, there are deficiencies which are directed against thrombin, its function against thrombin, some more against its function against factor Xa. And there are even mutations which render the effect of heparin, which basically is an anticoagulant, which amplifies the effect of antithrombin by 1,000-fold, where just this drug is not working. So there are very interesting different mutations. So how important is it to know then with the functional test to say, okay, it might be that, and of course you will need then a confirmation by a genetic test. So how does this let's say like accurate classification of such a patient influence the later, let's say, like management of that patient?
Maybe I would like to address this, because I had recently, in the recent years, two patients, and they had antithrombin deficiency. Yeah, so they had family history, they had thrombosis and antithrombin deficiency, and they got pregnant. So during pregnancy, you just can use low molecular weight heparin. So you need like you need normal antithrombin levels, or you have to increase the dose of the low molecular weight heparin. But if you have a type 2 deficiency with a heparin binding site defect of antithrombin, so you can increase the dose of your low molecular weight heparin. You will not reach the anticoagulant effect that you want during pregnancy for treatment or prevention of venous thromboembolism. I think this is very rare, antithrombin deficiency, yeah. But if you have diagnosed antithrombin deficiency, there are certain situations where it has a consequence here. Yeah? So in the second patient with a type 2 deficiency, of course, the idea was to give antithrombin and then anticoagulant therapy with a low molecular weight heparin, while in the other one with just a qualitative deficiency, so we could increase the dose of the low molecular weight heparin. This is just an example, just to show you that this might have a clinical consequence in our practice. Yeah.
Absolutely. Cihan, you mentioned a really important point there, that at least one of your patients had a family history. And I think that is a very important thing that helps to at least guide me when I'm deciding on whether or not thrombophilia testing would be helpful.
Yeah. But maybe, I mean, this is also, I think, an important question. So really, what are the characteristics really suggestive of inherited thrombophilia in a patient with venous thromboembolism? And I think this would be very interesting for our audience. And let's try to summarize this together. We mentioned, so if it's a young person, so thrombosis occurs in a young age, especially if there is no provoking risk factor. So if there is a provoking risk factor, you should not think of thrombophilia testing, yeah. But then, Lena, I'm just summarizing what you said. If you have a family history, just a strong family history, first degree family member affected also in a young age, so this is suggestive probably of inherited thrombophilia. And of course, if you have recurrent events at a young age, and sometimes I'm also doing this in VTE in unusual sites like splanchnic vein thrombosis, cerebral vein thrombosis, but this is the core group where I would be interested in testing for thrombophilia. Not everyone. Yeah.
Yeah. No, I would agree with that, Cihan. And I think it's also important to understand if there is a family history of thrombophilia, what is the thrombophilia, of course, because it doesn't always have the same individual consequence. So knowing that a first-degree relative has had VTE in and of itself is important and helps to predict one's risk of both personal recurrence and future strategies for needing anticoagulation to reduce risk of VTE in high-risk settings, for example. So I think it's important to know if it's one of the sort of hallmark natural anticoagulant deficiencies, or if it is factor V mutation or prothrombin gene mutation, which of course are more common. I won't necessarily test for those for an individual if there's a known family history, because it won't change management.
Yeah. But I think we were talking about like family histories and clinical signs of suggesting probably thrombophilia. The reason is, if we would do testing in unselected people and patients, so we have to do a high number of testings in many patients to identify thrombophilia. So, and I mentioned at the beginning, one of my first projects was to identify novel thrombophilic risk factors in people with recurrent VTE was the group. And in the majority of patients, in 60%, we didn't identify any of the known thrombophilic risk factors that we are talking about. So you will not identify thrombophilia, and many of the patients will not have a question. And then the question is, with this testing, yeah, can you avoid something? Can you avoid a clinical recurrence of VTE, or another episode of VTE, or first episode of VTE, if this is done in a person without established VTE here? So these are all important considerations here. Yeah, I like thrombophilia testing, but it should be restricted, and it should be done by persons, in my opinion, who are knowledgeable in who really to test, how to test, as you mentioned. So you need the proper assays here, and what the consequences are, and what the patient can expect. Yeah, what can we explain them? What are the clinical consequences? So this is all I would like really to emphasize today. Yeah.
Yeah, I think I mean, none of the guidelines really say that you should do a general screening. And then in looking at the, let's say, like the prevalences of these deficiencies, like how frequent they are really in the general population. And we talk about very roughly about like 1 in 10,000 who may have something like that, maybe a bit higher depending on the deficiency. While you have other prothrombotic, let's say, like mutations, the factor V Leiden, where you have also like people which have it's called heterozygote or homozygote. So which the heterozygote has a prevalence with like 4 people in 100. So that's a very high prevalence, although the risk with the heterozygote factor V Leiden is not that large. Only if you have like these homozygous, which is then again a bit more much more rare, that can be of relevance. Yeah, so just to give like a perspective, how frequent are these antithrombin or these protein S and protein C deficiencies actually if you are in persons? You have these clear triggers, unprovoked VTE. You have the family history, which is very, very important. So you have to talk to your patients. And yeah, the thing that's also like for me from the clinical practice. So what is in the end the consequence for someone who has something like antithrombin deficiency? You mentioned 2 cases. So does it impact their life? I mean, we know from other famous deficiencies like which go in the other direction into bleeding, like hemophilia A and B, that these are patients, they have this deficiency in this factor and they have to be treated lifelong for that. If they are not getting a gene therapy, that's a different story. But how is it with thrombophilia patients? I mean, they have now been diagnosed and classified. They have a protein S deficiency, as an example. What consequence does it have for them? I don't know. Any of you both?
I can start. So I think in the setting of an unprovoked clot where you do thrombophilia investigations and confirm, of course, you want to confirm that there's a protein S deficiency. I do think that It contributes to the decision for duration of anticoagulation. And again, if we're using this young 30-year-old male patient as an example, I think it adds to our knowledge of understanding what is the risk of recurrent VTE in a male with unprovoked clot. So I think it would add to my discussion about that risk of recurrent VTE and recommending anticoagulation long-term for secondary prevention. I think what we don't know is perhaps how severe a deficiency has to be before we cannot safely use some anticoagulants. For example, many of us are using direct oral anticoagulants in patients with protein C, protein S deficiencies. I don't know if they had a severe deficiency if I would do a dose reduction, for example. So we now have a lot of great studies showing us that dose-reduced DOACs for secondary prevention is as good as full dose for secondary prevention. And we're still waiting for some information to come from those subgroups that had thrombophilias. And so I think that would be an important consideration in a patient like this.
Yeah, just to add, I mean, I agree. Just to add, the thrombophilic risk factors, the thrombophilia is contributing to risk of a first manifestation of a thrombosis. I mean, but the question is here when we are talking about treatment decisions is one question is the duration of treatment. So and the question is thrombophilia impacting, or how is it impacting the risk of recurrence, that this will change my clinical decision? And I think there are primary risk factors for VTE recurrence, and this is whether the thrombotic event occurred spontaneously without a provoking classical trigger, unprovoked or provoked. Yeah. So, and then there is other clinical factors, but the role of thrombophilia testing in predicting recurrence is limited. Yeah. Yeah. So there is not this strong association with risk of recurrence, but there is one thrombophilic risk factor that would impact my management. Yeah. And this is not an inherited thrombophilic risk factor. This is an acquired one. And this is antiphospholipid syndrome or antiphospholipid antibodies. So it would be, so if there is a presence of antiphospholipid antibodies, so I would probably choose another type of treatment. And then, of course, it will also impact the duration of the therapy in such a person with persistent antiphospholipid antibodies. Yeah.
Yeah. What would be this difference, if I may ask? I mean,
yeah. So in patients with an antiphospholipid syndrome, so who are especially positive for lupus anticoagulant, and these patients are both at risk for VTE, but also arterial thromboembolic events, so stroke, myocardial infarction. So we have learned from studies that DOACs are less effective in preventing recurrent thrombotic event, especially recurrent arterial thrombotic events here. And here the recommendation is to use vitamin K antagonist. And in a person with persistence of antiphospholipid antibodies, I would not stop anticoagulation in such a patient. Yeah. I don't know if Lana is doing this the same, but yeah.
I agree. Absolutely.
Yeah, there are even some discussions, but especially if you have arterial events in antiphospholipid syndrome patients, there's even like the consideration to use antiplatelet drugs to specifically target that disease picture, let's say like that. So so yeah, we have these two, this acquired part, which is very relevant, and the inherited ones. I mean, there are also like acquired reasons for antithrombin proteinase or protein C deficiencies. That's also known. It's a bit rarer if I'm correct. So we have now, I think, covered when we test, why we test, how we manage the patient, and do you have any other remarks and important things you want to bring to our audience on that subject of thrombophilia?
Maybe my message would be before you test, identify the goals of your testing. And the second message would be, do not test for MTHFR mutation.
I agree with Cihan's recommendations. I also think it's important to understand when it's appropriate to test in individuals who have VTE and not necessarily to test family members of those who have not had VTE. So I know we didn't touch upon that, but I think that's an important consideration that often gets extended to family members of those who have had VTE.
And in this whole field, I mean, are you currently happy with the guidelines which are existing? I mean, there are ISDH guidelines, but there are also local guidelines. So are you happy with what we have at the moment, yeah, on thrombophilia or the specific deficiencies?
I mean, thrombophilia is a topic where we could have a debate for hours and for days. Yeah. So, of course, I mean, in guidelines, probably there are statements which where some of us is not happy with them. Yeah. But thrombophilia was in the past a topic of like discussions and debates, and it will remain a topic of debates and discussions.
So you expect guidelines to be, let's say, like that they will be revised and improved with over the next decades, if you want. Yeah. So there's so this is for me like what is your expectation for the future? What will maybe come? Will there be like new things play a role? New tests, new assays, new technologies like artificial intelligence? Do you have any, I don't know, view or vision of the future for thrombophilia testing or for thrombophilia management?
I think that you said it very, very well. We are going to be able to test for a lot more. As our ability to do gene sequencing improves, we will be able to identify more and more thrombophilias. What will be important is to learn whether or not they have any clinical implications. And so that, I think, is something yet to be seen. And I do think that it will impact guidelines in the future in a way that we can't yet know.
Yeah, I mean, the question would be, will thrombophilia testing help us to personalize treatment in the future? Because we are doing more and more personalized treatment, yeah. And let's see what new technologies will bring for the future. We have to learn this. We have to see this in studies, yeah. And I'm looking forward to such progress or advances to more personalized treatment, and whether thrombophilia can help us here to go this way and to this path.
Yeah, I think we had a very interesting discussion. Maybe everybody has like now some 30 seconds to summarize their, let's say, like their key takeaway for our audience of that discussion, what we just discussed, and we covered, I think, most of the relevant subjects. So let's start with Lana. So what would you give back to our audience for that from that webinar?
So I think I would reiterate the importance of understanding the inherited thrombophilias as well as the acquired thrombophilias and the appropriate clinical context in which to assess for them and how it's going to impact management.
So I think we had a great discussion today on many topics related to thrombophilia. So thrombophilia is exciting. So it has really pushed our field when we go to the past, especially when we think of the identification of APC resistancy, factor V Leiden mutation. So it gave a dynamic here. So it might have a role for some patients here, and you have to carefully pre-select patients here for thrombophilia testing, also considering psychosocial consequences of a positive test here.
Yeah, for me, also to wrap it up, I mean, it was very very interesting discussion, also like from our different points of view, and from, let's say, like a diagnostic company point of view. It's of course important to learn that we should work together with the clinicians to really understand, okay, what do they need to improve diagnosis as well as patient management in that condition, which can be fatal, yeah, because if you have a deep vein thrombosis, you might have pulmonary embolism, which can cost you your life. So that's why it's relevant, it's important. So with that, I would like to wrap up our discussion, and I would like to thank Dr. Castellucci and Professor I for their participation in this webinar for the World Thrombosis Day. And of course, I would finally again thank the ISDH in the name of Sysmex that we had this opportunity to support this webinar in the name of the World Thrombosis Day. So thank you very much, and I hope you enjoyed our webinar. Bye.